Okay. Good afternoon, good morning, good evening, wherever the participants are connecting from. I would like to welcome the panel members and also our collaborator, Dr. Dilip Mavlankar, on this webinar series, which we started on 19th August on promoting health throughout the life course during COVID-19. We are almost 10 months into COVID-19 pandemic, and we know that we all understand it's not going to leave us soon. Today is a very happy moment as well as a not such a happy moment, because we started our first series in collaboration with the Indian Institute of Public Health, Gandhinagar, on 19th of August, and we are now in the end. So there were 11 webinars which were organized throughout the live course, starting from newborn children, adolescents, pregnancy, COVID in children, as well as older adults or elderly people who are most affected. So last webinar of today is going to focus on options to maintain essential health services during COVID-19. And as you know that there were direct impact, and there was also indirect impact of COVID-19. Direct, it affected a lot of older people, and it has also caused a lot of mortality. Indirect, because there was disruption of services, health services as well as other services, but essential health services were disrupted during lockdown periods, and as well as because the health system was gearing up to respond to this kind of pandemic. We undertook mapping of service disruption of sexual, reproductive, maternal, newborn, child health, adolescent health in 11 countries of Southeast Asia of our region. And we found that disruption was definitely there, but it was of varying degree in different countries based on the duration of the lockdown, based on many of the demand side factors as well as provision side factors. Demand side, because many people were scared of going to the hospitals because of the infection. There were issues related to transportation, finances, fear, but then provision side factors, because a lot of health workforce was also repurposed to look after the COVID-19 pandemic. And then we also had one webinar on task shifting, task sharing during this period. So I would like to first of all welcome all the panelists, starting from Dr. Tana, who is a team lead in Academy of WHO Geneva, Dr. Manjula Narasimhan, who is a scientist in Department of Sexual Reproductive Health Research in Geneva, WHO Geneva. These are two colleagues who will be throwing some light on some of the issues. And Ms. Saida, who is a midwife in Uppsala Health Complex from Bangladesh. She'll be sharing her experience how midwives can contribute to provision of SRH services. And Ms. Suchitra Dalvi, who's the coordinator for Asia Safe Abortion Partnership board member from Inroads. I'll also like to welcome our collaborator, Professor Dilip Mavlankar, who is the director of Indian Institute of Public Health, Gandhinagar, and Dr. Meera Thapa Upadhyay, who is my colleague, who will be, moderating this session. So, as I said, we are going to have 4 presentations. First is going to be on health workers training to maintain essential health services from Dr. Tana. Midwives, their contributions to maintain coverage of sexual reproductive health services from Ms. Saida, and self-care interventions to support maintaining essential health services for SRHR by Dr. Manjula, and demand of SRS services in community from Ms. Suchitra Dalvi. as I said, this is our last 11th webinar in the first series, which we started on 19th of August. There are other two webinars which are simultaneously also going on. We are organizing around 16 webinars on COVID in children by our WHO Collaborating Center in collaboration with WHO Zero. We keep sending out the invitations on that, and there is another webinar series which we started on school reopening in collaboration with UNESCO, UNFPA, UNICEF, and WHO. So it will be also coming up soon, and we'll be sharing the information with you. Although this is the last one, but I would say it has been a very, very successful webinar series. But then this is not the end of it. We are going to come back again in collaboration with our partner IAPH on the next series, because we have found a very overwhelming response by the participants, and there is a demand for this. So we might be sending you some evaluation form to really understand how much you gain and what kind of additional webinars you would like us to address later. So with that, I would like to hand over to Professor Dilip Mavlankar to tell us a bit more about Indian Institute of Public Health, Gandhinagar, and then I'll hand it over to Dr. Meera to take us through this process. Over to you, Professor Dilip Mavlankar.
Thank you very much, Dr. Neena, and thanks to WHO for this innovative step of organizing a series of webinars. We were very delighted when WHO came to partner with IIPH Gandhinagar on this. The Indian Institute of Public Health Gandhinagar is a public-private partnership between the Public Health Foundation of India and the provincial or state government of Gujarat. We have a beautiful campus of 50 acres, and we are the first public health university of India. We offer Master of Public Health and Master of Hospital Administration courses, as well as postgraduate diploma in public health management and many short-term courses. With the pandemic coming, we also help the government in developing various control strategies, as well as helping the cities and local administration in support to the pandemic activities. And the webinar series was one of these activities. We also held several other webinars to understand the disease and bring various experts to know about this new disease and how it can be stopped. We are very keen to continue this knowledge exchange, because as the first public health university, it is our prime mandate to develop and disseminate knowledge wherever it is. And we are so much delighted that in today's panel, we will hear from people who have a lot of experience from WHO, from Bangladesh and other countries, including India. When the pandemic hit, in India, we have this mythological story that Arjun was asked to hit the bird with its eye. So the whole health department focused every attention to kill the virus and stop its transmission. But in the whole effort over last 8 months, we forgot that rest of the services are becoming paralyzed and almost stopped. And now we are realizing that we need to rebuild whatever is the lost ground and ground up from primary care to secondary care to tertiary care, whatever had been stopped by the government, as well as people stopped coming because of the fear of getting the infection in the hospitals and health centers. So both sides we need to work, and I'm sure today's webinar will highlight what steps we need to take, what has happened, and how do we rebuild people's confidence as well as health workers' confidence. I want to just say that this is a unique pandemic where doctors and nurses are also afraid. In most other medical emergencies, never have it been that doctors and nurses are afraid, except maybe military conflicts or something. But other than that, this is first time that even the health workers really need to be protected when they provide the services. So with that, let me again thank WHO and all the panelists, as well as all people. Almost 200 people have joined this webinar now who are listening very actively to this. Let's start the webinar. Thank you very much, Dr. Neem.
Thank you, Dr. Professor Dilip Mavlankar. I think we all understand there are a lot of estimates of how much maternal mortality, newborn mortality, child mortality may have gone up, how many additional deaths may have happened during this period when there was disruption in services. Needless to say that there were, access to contraception, was the least of anybody's, problem. A lot of attention, thankfully, started to happen on women who had to deliver, those who were already pregnant. But since we have been, into this pandemic for almost, 10 months, the real challenge is how many unwanted pregnancies have happened, how many clandestine abortions may have happened, how many unsafe abortions may have happened. And I think that's where, irrespective of the legal status, whether it is permitted or not, I think access to contraception to women to avoid pregnancy was a real challenge, especially during lockdown periods in many countries, which were extended in some countries for months. So I think we have a very, very wonderful, I would say, panel members who are going to take us through and who are going to share some of the experiences with us and how WHO has responded, how self-care guidelines are going to help during these difficult times. I think these are some of the things we are going to really listen to. Since I think a lot of people have connected, I see there are about 200 participants who have connected. And since this is the last webinar of the series, which we started on 19th August, I would like to put on record and my, appreciation to Professor Dilip Mavlankar and his team for really, letting these webinars be run through so, without any glitches, very, very well. Thank you, Professor Dilip Mavlankar and team, especially, Kalpana, Neeraj, and others, these 2-3 names I know who have been interacting and sending us emails. I'm also very, very grateful to my team, and I'm very happy that the nodal person who was for this webinar series from my team was Dr. Meera Upadhyay, and she is going to be moderating the last webinar too. So a grateful thanks to Dr. Meera Upadhyay. We are very fortunate that you are here with us. And I would like my team member, Mr. Amit Sood, also to switch on the camera if you have access, Amit. I want to acknowledge, these two people from my team who really work day and night to make sure that every week a webinar is done properly, the information is gone out to those people. So I would like to also put on record my appreciation for Mr. Amit Sood. And, I would like to say that all these webinars are there on the YouTube. And we have been sharing the presentations with all of you, those who participate and those who also register. So that we have permission from the presenters to share these presentations. So we have been sharing we are going to be coming up with the summary report of each webinar with the PDF files of the presentations. And these are already 9 webinars, I understand, are already up on the YouTube. And we can share the link in the chat box. Amit, please do share the link on the chat box so that everybody, those who could not participate, can also refer back to it. I would like to now hand over to Dr. Meera Upadhyay to take us through the presentations for today's webinar. Over to you, Dr. Meera.
Thank you, Dr. Nina, and thank you, Dr. Dilip, for supporting our webinar series throughout this year and throughout these 2 months. The first presentation we are going to have is related to health workforce, because we know we really have a problem with the number, with the skill, and many things around health workforce during this COVID. So it's not only about the managing case, it's about how the communication is happening, what are the skills, how much knowledge do the health workforce have. So it's about the overall competency of the health workforce. So I'm sure Dr. Tana, she is the team lead from WHO Academy WHO headquarter. She would be making a presentation on health workers training to maintain the essential SRH services. So we will hear from her, we'll learn from her more about the health workforce related activity. Following this, then we will immediately hear from the midwives person, like how they are managing a COVID, the cases during this COVID pandemic in a Upajilla, that's in a district level facility. So having said this, now I welcome Dr. Tana to make her presentation. Thank you.
Thank you very much for that introduction. It's my great pleasure and honor to be with you today. Good afternoon, good morning to all. With the WHO Academy, this is really one of the priority initiatives of WHO as part of its transformation in really trying to accelerate the way we support health workers in particular, but also policymakers, decision makers, public health officials, and others in the community to have the competencies they need to tackle their work and improve performance from a lifelong learning perspective. Things are changing and evolving all the time. So I'd like to tell you a little bit more about the Academy and how we can use some of these concepts to support health workers in maintaining essential sexual and reproductive health services at this time. Next slide. So the Academy is really trying to take the best of the science in adult learning, as well as the latest developments in technologies that allow us to support learning to be more in line with the needs of the learners. I think we have all had a lot of experience in training over the years, and we've seen what works and what doesn't work. And one of the challenges that we all face is really trying to get at the heart of what each individual learner needs, and it's not always the same. We have people with different levels of background experience, different qualifications. They're being asked to perform different roles throughout their career and occupation. We also know that when we look at the literature on how long does it take to implement guidelines, that this can take quite a long time indeed. So it's in our interest to find ways to sustainably and systematically have a better way of supporting lifelong learning to improve health outcomes. Next slide. WHO is, if I could have the next slide, that'd be great. WHO is a major provider of training and lifelong learning. In fact, the organization is providing over 1,400 courses across the world. We use over 20 different platforms. However, the challenge is really that this training is not necessarily streamlined or accessible all in one place. With the Academy, we are bringing in the latest standards in this area. We are trying to do this at scale, offer multilingual learning, and also to work with other players in this space, other institutions, organizations, civil society, professional associations, partners, etc., and member states to be able to do this in a way that's really agile and responsive at this time. Have the next slide, please. If we could go to slide 4, that'd be great. So the key here is really to optimize learning. And we know that in the science of learning, this is a process by which each person is taking into account the experiences they're facing on the ground with theoretical knowledge they're building out. And this is really a cyclical process. And with the Academy, we want to find ways in which we can support this cyclical process of learning that's very natural and intuitive to all of us to be more effective, efficient, and sticky. Because while we're very good at learning, our brains are also efficient at kicking out things that we're not using immediately. And so we also have challenges with retention and maintaining what has been learned over time. If we can go to the next slide. The Academy approach is really to bring together and combine the state-of-the-art inputs. So that means combining not just the global health or the public health expertise and experience. It's about bringing together into that the science of how people learn. And that means that we can imagine ways in which to use different disciplines like behavioral science, like apologies, there seems to be a technical glitch. If we can just go to slide 5, which is the Academy approach, that'll be wonderful. Excellent, thank you so much. So we have here an opportunity to bring together these different inputs and to offer a process of learning that is going to deliver better impact. So with the science of learning, we're not just interested in the behavioral science, the sciences around how people actually learn and develop in the most optimal way. We also want to look at the technologies and how that can actually enhance the learning outcomes. And we also know that people deal with very challenging situations on the ground. So what we learn as the ideal is not necessarily how we're expected to practice. And understanding human performance science and complex adaptive systems is really going to help us to support every learner to be able to take what they're getting from the learning experience and put it into practice, which is the most important thing. The process of learning that we're imagining through the Academy is really very immersive. It's very applied. It's going to support the learner to integrate these different concepts and competencies into their behaviors, and also to do that with others. Learning is a very social experience. We build up meaning, community, understanding, and shared experiences. We also want to recognize what people have gained in the learning experience. That means whatever expertise they come into the learning process with on their own, as well as what they gain out of it. I think a lot of lifelong learning systems are really prioritizing things like the time spent learning. For example, we're all familiar with continuing education or continuing professional development credits, and we do recognize and put value on the time that people spend learning, but it is challenging for health workers to get recognition for the competencies they've actually gained, their learning achievement. And this is the opportunity we have now to move towards a system of recognizing or credentialing competencies gained and to stack them up in ways like Lego that really fit with the profile of what's needed. Around this, we need to research and innovate. We need to understand what kind of learning works best for different people, in what context, where it matters to have particular immersive experiences so we can improve the performance. In terms of the outcomes of learning, we of course need to engage the learner. This is about taking a learner-centered approach and designing learning that fits in with the lifestyles or with the context of the learner, what we would call learning personas. And then we want to understand if they're actually learning, what competencies are they building in this journey, and therefore what behaviors are they able to implement in their work and life. And it's only then that we can expect an impact. So if we're designing lifelong learning for addressing the disruptions that we're seeing across the world in sexual reproductive health services, we need to reverse engineer and understand all these elements so we can really have something that's meaningful and that fits in with the very busy lives and context of health workers in this high pressured environment. Next slide. The learning experience of the Academy is therefore something that we want to apply design thinking to, and also, based on these learning personas. A lot of the learning we'll be offering will be digital, but done in a way that can be accessed offline, because of course many health workers do not have ready access to data at all times. We want this to be multilingual. that they can also access and search other resources that are going to help them to be connected with other colleagues around the world as they're trying to implement these changes, and that the process of learning is very interactive. So as I said before, it's about giving as many opportunities as possible to practice and to engage in others. So everything from the design of the assessments to see where the learner is at, the experience of actually building up proficiency or a level of comfort in the competency they're trying to implement, exercises to practice as much as possible, and getting feedback. This is really going to consolidate and strengthen the learning. I think we all know that when we have presentations or what's known as very didactic learning experiences, the retention is very limited, and some studies suggest that learners only take away about 7% of what they learn in a lecture. If we can go through this much more immersive experience, we can then see and judge from an assessment that looks at what they're able to do. We can recognize that with a digital certification of the competency gained, to actually see what they're able to perform now and not just what they can remember or recall in terms of knowledge. Next slide. There are a number of ways in which colleagues will be able to access learning through the academy. So digital learning, as we discussed. We also see the importance of in-person learning, and that could be done in different ways. We will be having a campus network established over the next few years that will take time, with its main hub in Lyon, France. However, we do also work right now on developing what we're calling a portable learning lab. So this is like the academy in a backpack that can be deployed and used offline in hard to reach areas or in institutions. And this is something we will be prototyping and implementing next year. Next slide. There are a number of courses that we have in production right now. One of the first courses we're actually launching at the end of this year is a competency-based module on maintaining sexual and reproductive health services. We are doing a learning needs analysis right now, a survey in the official languages of WHO to get feedback from health workers in particular to understand what specific learning gaps they have that would help them to address the disruptions to sexual reproductive health services at this time. Next slide. This is the app that we launched in May, and this was in response to a very high demand from health workers who were feeling quite overwhelmed and struggling with accessing the growing level of guidance and different courses that were on offer from WHO. So this is a one-stop shop app of the WHO. It's available in 7 languages. Colleagues can download this freely on Android or Apple phone. You've got the QR codes there, so if you hover your camera on that code, you'll be able to get the app. With this app, you can access all the courses that WHO has right now, the different webinars that regional offices, headquarters are offering at this time, as well as recordings, and search through all the WHO guidance. We developed a mobile app because we did a survey in which 22,000 health workers from 178 countries participated. And over 70% of health workers said that the main device that they use to access information and data is are their mobile phones. And so we were thinking, how could we actually make it more convenient? And we are looking to deploy the sexual reproductive health training through the mobile phone as well. So something that health workers can engage in as and when they can, self-paced, a few minutes at a time, to practice and build their competency. Next slide. We have a new experience that we'll be launching on the 4th of November. It will give you a proof of concept of how new technologies like augmented reality can bring learning closer to the learner. This is a course that takes about 20 minutes to complete. It will allow health workers to go through an interactive instructor-led experience where you have a virtual nurse on your phone that you can bring into your own living room or environment or hospital, who will take you through how to put on and take off PPE and how to avoid the most common mistakes in the use of PPE. Health workers will also be able to earn the first digital credential of the academy, and this also will give us good insight into how technologies like this can be used to make learning more memorable and more effective, and therefore more implementable for health workers, and we'll be continuously improving upon this over time. For those who do not have smartphones that would allow augmented reality, there is a video version and will be accessible offline as well. Next slide. As you can see with the Academy's learning model, we are trying to combine a number of different things. Over the years, we can also use augmented reality to make the learning even more personalized, more immersive, give assessments that are adjusted to the specific needs of the learner. And we will also be working towards supporting more and more networks and shared learning opportunities. We know from the science of adult learning that those who help others to learn are more effective in learning themselves. Next slide. There are a number of ways in which the Academy is different. We're looking to combine multiple platforms into one. We want to make the learning more targeted. We want to base learning as much as possible on real-time learning analytics and learning analysis of needs, so we can be very responsive and agile. And it's about co-creation. With this, I have with me here Dr. Sarah Borg, who's leading the development of this course, along with the Sexual Reproductive Health team in WHO, spearheaded the team there led by Dr. Manjula, who's going to speak in a moment. And we want to co-create this course as much as possible so that it meets the needs of health workers. And we also take into account the perspectives of patients and communities as we're doing this. So it's great to see civil society engaged in this webinar. Next slide. There are a number of ways in which we want to partner with others, and there are a couple of opportunities here. I won't go into each one of these one by one, but you will be able to find out more on our website. Next slide.
Anna, you have only 2 minutes now. Yep.
Thank you very much. So in summary, the time is right for this approach to lifelong learning. I think we're seeing with COVID-19 what urgency and importance there is placed by member states in learning that has an impact. I think with health workers in particular and growing restraints on their time, we need to be as responsive and we need to cut to the chase, so to make sure that our energies are directed towards building real competence that's going to help health workers in particular in a very practical way. Next slide. There are ways in which we can bring this together to accelerate learning. This module we're rolling out at the end of this year will provide a good opportunity to apply these approaches, these principles, and we look forward to working with other colleagues to make sure that we can meet these demands and expectations in a way that will actually generate support to address disruptions to sexual reproductive health services. Next slide. What is important to recognize here is that there's a lot at stake. As we know, these disruptions have very real impacts now and long-term consequences as well. This is really important so that we can understand and prioritize where we need to act and how we need to provide the support so that health workers feel equipped and comfortable to take on new roles, to work in new models of care, to implement changes in the care process so that these disruptions are not felt in the way that they're being felt now. Next slide. With these learning solutions, we want to arrive at something that is competency-based. This is just the starting point for the Academy. Next year, we're looking to really ramp this up further, and we would love to hear from you to get your feedback, suggestions. As we said, we are implementing a very aggressive process right now so that we can launch the first learning solution by the end of this year. We'll be happy to take any questions, and Sarah's here as well to support. Back to you. Thank you very much.
Thanks, Sana. Thanks. So this is thank you for giving us lots of information and lots of link about the innovative training or capacity building approaches that we have through WHO Academy. And thank you so much. Now we'll move to the other presentation. Mrs. Saida Mahfouz Akhtar, she is the midwife herself. She has been working in an Upazila hospital. And she has been in a ground when she's managing a COVID cases in that district on the self-care intercourse and published recently by WHQ. So I welcome Manjula to make her presentation now. Thanks. Thank you. The floor is yours, Dr. Manjula.
Thank you so much. Thank you so much, Mira, Dr. Nina, Dr. Professor Dilip. Thanks very much for this opportunity. I think it's really terrific. my connection seems to be a little on and off, so I hope you're hearing me. And next slide, please. I'm going to be speaking on an opportunity that we have during this terrible pandemic to help individuals and families and communities, but also to support health systems in ways that that are not entirely new, but that can be ramped up to advance health, and particularly sexual and reproductive health. And earlier we had mentioned that there was a guideline developed around self-care interventions for health. This was published in June 2019, so last year. And what I'm going to do is speak for, for a few slides, cover some of the background that we had prepared for that guideline and that informed that guideline, both in terms of the definitions that we are using within WHO, also the framework, and a couple of key elements that we think are important in order to introduce and scale up self-care interventions at country level. And then I will continue the presentation with going through some of the elements that would be relevant during this COVID pandemic. So firstly, to start off, in terms of the terminology that we're using, the self-care more broadly is something that every culture, a lot of countries in CRO are already doing and have been doing for millennia. And it's really the ability of the families and communities to undertake a wide range of health issues, whether it's to promote their own health or maintain health, whether it's supporting caregivers and those that they're caring for, or to support individuals themselves with or without the support of a healthcare provider. The self-care intervention is something that we see as a bit different to self-care more broadly. And it's really about the tools that we now have. And these are evidence-based tools that can either support better diagnosis, that can support new technologies. And again, this is to be used by people themselves with some element of link to health systems, and the linkage with health systems will depend on the different interventions. So just as an example, the self-care now that we have during COVID could be the hand washing or the physical distancing measures that are in place. And if, better nutrition or, taking care of your health and doing exercise and eating better and staying physically active and being connected to people. Self-care interventions are those tools such as an HIV self-test or a pregnancy self-test, or managing medical abortion through access to, for instance, contraception over the counter, different elements and actual interventions that people can undertake in the safety of their home and at the time and at the place that they would need. Next slide, please. And the work that we're doing within WHO is really, it's about promoting health, keeping people safe, and serving the vulnerable. And it is the triple billion goal that many of you may have heard of and was already mentioned earlier by my colleague Tana. And this is really something about the self-care interventions being an opportunity to improve not only health coverage with acceptable, affordable, accessible interventions, and it's about also protecting people who may be in health emergencies. This is beyond just the current pandemic, but also it could be people in migrants or refugees and in other humanitarian crises or post-conflict settings where health systems are overstretched and where self-care interventions, if made available and if made available through supportive means can offer alternative ways to support individuals. And it's also about improving health and well-being. So we're moving away from specifically sort of a disease perspective to talking about the goals of individuals more holistically and supporting the individuals, the families and communities to optimize their health. Next slide, please. And so the conceptual framework developed by WHO for self-care interventions places people at the center of this process. So it is a people-centered approach where we acknowledge that improving their autonomy, their agency, is a really important means of enabling them to make informed health decisions. But we need to do that in context of principles that support a human rights approach, that look at the gender equality means so that we're not adding further burden on individuals. This is not about giving interventions to individuals and saying, now it's up to you. It's really to give them interventions as an additional choice. We acknowledge that people are more and more accessing health information, health products outside of formal health facilities. Yes, they are still going to health facilities, but maybe they are getting information online. Maybe they are accessing products over the counter. Maybe they are getting it through their communities and using digital technologies more broadly to connect with health providers. And I'll say a little bit more about the enabling environment, but it is important that we make sure that people are within the context of a safe and supportive enabling environment, and that they don't feel abandoned by health systems. So this is, again, as I said, additional options that we're providing not only to the health systems, but to individuals. And then that means that the accountability, not only of the health sector, but from the government and the private sector and others, remains intact. We are accountable to the kind of quality of products that we are providing, and making sure that they are used and the uptake and the retention and care, if needed, is still possible. Next slide, please. And so just a little bit about these characteristics of that safe and supportive enabling environment. What we would ideally like is that there is commodity security, that there is psychological support if that's needed, that there's supportive laws and policies, but there's also access to justice. And that people have access to food and clean water and education and appropriate information, and that they have the finances to be able to get some of these services, that they have regulated quality products, that they have a trained workforce that know that they can promote self-care interventions as an additional option. So there's that training that Tana was mentioning earlier is a critical element. And very importantly, and we've seen that this is something that is unfortunately risen during COVID, is the violence, the coercion, stigma, and discrimination. So the protection from these elements are really, really important. And again, self-care interventions may offer a possibility to individuals to maybe overcome some of these elements within an enabling environment. Next slide, please. And when we published this guideline in June 2019, we knew that self-care and self-care interventions was going to be very important. This was a priority already at that time. And then when COVID hit this year, it has really placed this aspect of health care delivery in the forefront. It's really something that has become very important in elements such as the hand washing or the physical distancing that I mentioned earlier, but also in other elements. And certainly when health systems and health facilities are overwhelmed, self-care interventions really offer these new opportunities that we should use. So the next slide, I just wanted to share a couple of examples of how this could be, particularly in relation to sexual and reproductive health and rights. So again, this was mentioned there. A guidance was developed by WHO in June of this year on maintaining essential health services during COVID. And in this guidance, and the link is provided here, in this guidance, you've got sections on sexual and reproductive health, on maternal, child, adolescent health, on HIV, STIs, NCDs. It really covers a lot of the health services that are really critical at this time beyond the services for COVID. And if we look at the sections on each of those health sections, you will see that throughout it is peppered with self-care interventions, really interventions that need to be prioritized now when people are not able to come in to our health facilities or are fearful to do so. Interventions that they can do in the safety of their home, interventions that they can be supported through telemedicine or through digital means. So I'm just going to share some examples. This is not a complete set of examples, but just a few, just to give you an idea and to start a discussion around other opportunities that might exist around these self-care interventions. Next slide, please. So one is the use of the digital technologies, and it could be something related to, for instance, client to provider telemedicine, to not only provide services, but to give counseling at a distance. And this could be referrals for self-administrating an injectable contraceptive, or for sharing results related to an HIV self-test, or another a pregnancy test, and wanting to get advice. And it could also be about the health system connecting with a client to say, look, it's time for a vaccination, or giving education around condom use, or sexual health or safer sex messages during this time. And Dr. Nina mentioned that there's been a rise of unintended pregnancies, and people really still needing accurate information that this provides an opportunity for. It's also about, as I said, notification and reminders for medicine adherence. Next slide, please. Availability of over-the-counter medicines and informations and diagnostics and other pieces, and quality regulated products is really important. And so increasing access to, for instance, condoms and lubricants, or an HPV self-sampling for screening of cervical cancer, or prioritizing, menstrual products and menstrual hygiene products through over-the-counter, could, and providing support to pharmacists and drugstores to carry a broader range of contraceptive options may be, well, we know is already an additional opportunity to increase those contraceptive means for people who, again, may not be able to see their healthcare provider, may not be able to access a health facility for a variety of reasons. Next slide, please. And just as the last example, this the other way could be also about access to referrals and health facilities. So the self-care interventions is not necessarily just to be done at home. It can be done to reduce, for instance, antenatal care contacts for low-risk pregnant women. Like as I said earlier, you know, the advice can be given through digital means, but it could also be about identifying, for instance, safe houses or shelters for women or other individuals who are facing violence at home and would need to be placed elsewhere and quarantined elsewhere, for instance, to and that care is provided to them in places other than within their homes, but it could still be giving them, empowering them and giving them a sense of agency and autonomy to act upon their health needs and their health choices and their health priorities. Next slide, please.
Yeah, Manjula, you have 2 minutes left.
Sure, yeah, this is going to be really quick. So I just wanted to share that we have a communication toolkit where a lot of the technical and communication material available in 6 UN languages is there. It would, you know, you are very welcome to use this. We're happy to share this after this webinar, and it's really for countries, for partners to use and to to promote some of these interventions, particularly during this time of COVID. Next slide, please. And we've also established a community of practice on self-care interventions, and the link again to connect to this community of practice is noted here. And this is very much for partners in countries, partners in the region, to connect with one another, share experiences, and find ways to advance sexual and reproductive health and rights in a way that where we can not only share evidence information, reduce the amount of false information that's circulating, but also make use of a community to promote the guidance that is now available, and so that we can introduce and scale up these interventions to support people and the health facilities. I think that's the last slide. Next slide. Thank you very much.
Thank you, Manjula. Thank you for sharing the Knowledge Action Portal for all SRHR, for the partners and stakeholders who are working on SRHR, especially to promote the self-care guidance and the interventions during this period of COVID pandemic. Now I request, now I think I will go back to Suchit. Yes, Saida, I request you to make your presentation. Saida, are you there? I welcome Saida to make your presentation.
Saida, can you please unmute yourself and start speaking for your presentation?
Yes.
Thank you.
Yes. Hello, everyone. So my name is Soeda Mahfuja Jhumu, and I'm a midwife working in an Upazila health complex over Dhaka, Bangladesh. And I'm the Vice President of Bangladesh Midwifery Society. I would like to thank all of you for, I would like to thank Tanimiju and WHO for giving me this chance to present the contribution of midwives in Bangladesh in this COVID-19 pandemic. And I would like to go through my presentation. The next slide, please. Yeah, here is my agenda of my presentation. Would like to draw your attention. I will be presenting the midwifery scope of practice in Bangladesh, the effects of COVID-19 to demand of essential health services and midwifery services, and how midwives made sure essential SRH services were still maintained during COVID-19, support from the Professional Association to midwives, administrative policy changes that affected midwives during COVID-19 pandemic, and the last one is challenges. Next slide, please. The midwifery scope of practice in Bangladesh. So the first batch of diploma midwives were deployed in 2018, and before that time the nurses were doing the SRH services, and in Bangladesh we have 1600 certified midwives who are trained for 6 months additional training, and who are actually nurses. The midwifery services includes all reproductive healthcare services like awareness building, preconception care, antenatal care, postnatal care, family planning, normal delivery, gender-based violence management, adolescent care, mother and neonatal health services, etc. The midwives are deployed in the Upazila health complexes, that is sub-district of that area, and they are providing BMONG services to all the people. The midwives also provide postpartum, post-abortion family planning services. Next, please. And the 1149 midwives are working in 342 Upazila health complexes and 25 union sub-centers. And every UHC there are 4 midwives who are working in one Upazila health complexes. The midwives are working in the different area with private projects as well from the other NGOs like international organizations where there is a demand of midwives in this COVID-19 situation like BRAC, OGSB, RTMI, MSF, IOM. And midwives are providing as SRH services in the Cox's Bazar camps for refugees even in this pandemic situation. I would like to go to the next slide. Yeah. Here is I'm showing a graph. You can see the graph. There is the ANC services. Yeah, the number of ANC visit in the hospital at that time sudden drop. You can see the number of patients were not coming in the hospital from March to April. A sudden fall of the visit. Yeah, and the same goes for the PNC. Next, please. The same goes for the PNC visit. The people were not coming in the hospital from March to April, and the number of patients were decreasing. And it is sustained for 2 months, and now it is increasing, but not like before. Yeah. Next, please. So the normal delivery rate is decreased also, yeah, from March to April. Please read the graph. Yeah, I will not take too much time. Yeah, the number of patients are decreased. The thing is the effects of COVID-19 in midwifery services. The pregnant mothers are afraid of their own and their baby's health during this pandemic. People spreaded rumors that a lot of COVID patients are admitted in the hospital, but that hospitals are not disclosing the information. And many midwives also got affected, which made it difficult for other midwives to continue providing services. Because of COVID situation, it was necessary to maintain a separate delivery room for suspected patients. It took time to manage the separate room at that time. Next, please. As shown in the previous slides, during this corona pandemic, the number of pregnant women coming into the facility decreased. They were not coming for ANC, PNC and delivery. And what I do, I would like to share my experience here. I went to the community with doctors and UHFPO. UHFPO means the local authority of the hospital, and told the people to come to the hospital and promised them to give their expected care like before. Since UHFPO has a good rapport with the community, ensuring that health services are available 24/7, gave reassurance to the people. And we went twice to the community to counsel the people. We also we had a tracking system with the women who were coming for ANC and started calling them to inform to come to the hospital, to Opozela Health Complex for their betterment. And after every delivery, we started explaining and started counseling the mothers to tell everyone to come to the hospital, and that they don't need to be scared, and also told them to wear mask and nothing to be worried if everyone maintain measures to protect themselves and others. So these were more about the health education. Next, please. So here we have support from a professional association, that is Bangladesh Midwifery Society, and BMS active members received 82 free online courses, including COVID-19 learning materials. BMS provided cloth masks, gloves, face shields to all Opozela health complexes where midwives have been deployed, and to the private sector where BMS has its member. BMS is providing virtual help by providing continuous information and offering help, and it has a hotline started in this pandemic to provide members a support system. The hotline number belongs to the Secretary of Bangladesh Midwifery Society. Next, please. And during this pandemic, Bangladesh was affected by a major cyclone, which caused flooding in 1/3 of this country. And BMS has a quick response to the flood affected areas, and for the midwives. BMS distributed birthing tool, ball, mobile phone, and VD kits and PPE. And BMS is communicating regularly with the coronavirus affected midwives, providing them free online membership enrollment support, or any other support like as per their need, like sending them some fruits, vegetables, mobile internet recharge, etc. Next, please. And administrative policy changes that affected midwives during COVID pandemic. So the DGNM is the administration for the nurses and midwives. So DGNM started providing information regarding COVID-19, how it spreads, prevention, necessary steps for midwives and other healthcare providers every day by email. And DGNM provided lots of PPE, including gloves, masks, hand sanitizer, gowns, goggles for the safety of the midwives. The government declared incentives for all healthcare providers. If anyone gets infected with COVID-19, one will be given an amount of money, and if a healthcare provider dies because of COVID-19, one will be given a larger amount of money according to their salary scale. And the government offered another general incentive to healthcare providers, including midwives, nurses, and doctors. These healthcare providers will receive a one-time incentive of 2 months' worth of salary. All the steps taken by the government really deserve praise. Next, please. Yeah, I would like to go back in the 4 slides, please. Effects of COVID-19 in midwifery services. Could you go back? Not this one. The previous one. Yeah. Yes, this one. I would like to share one of my experience with all of you guys. The thing is, it was a little bit difficult for the midwives to continue proper care at that time. For me too. The thing is, the number of midwives are really poor in Bangladesh. Also, it is a very new profession, you all may know. And I just came from the maternity leave on 10th of April, and just after joining had to do 24 hours duty, because there was an order from administration to maintain a roster where the less nurses, midwives will be on duty, so that all of us don't get affected at the same time. We were only 4 midwives at that time, and if I could do 24 hours duty, got 4 days off. So what happened is, in the beginning, proper quarantine was not maintained. So 4 to 6 days is not proper quarantine, no. I would say that there was a gap of critical thinking on that time. So I was in postpartum depression and scared of my baby. Even I could not breastfeed my baby properly. So 24 hours duty is really tough for all. It happened not only with me in the roster. Many midwives midwives and nurses were suffering for that. And I would like to go to the last slides, that was challenges. Yeah. The human resources, because that during COVID-19 pandemic, the demand of for midwives increased twice than the normal situation. So registered midwives government employment is very essential. 1 to 4 midwives in one Upazila health complex is not enough. And we had lack of knowledge, proper knowledge during this pandemic. So midwives really felt the general training was not to manage any kind of pandemic situation. And we had a shortage of PPE in the beginning. Government could not supply PPE in the proper time, and that hampered the confidence for a while. Yeah, I have almost finished. If you have question, you can ask me. Thank you. I think I have finished earlier, no?
No, thank you. Thank you for keeping up with time. You're 1 minute earlier, Saida. Thank you so much for sharing your experience. And you and the cadre, the midwifery cadre and the cadre who are working at the ground level, we are very grateful for you all. And it is your services is really appreciated throughout the world, and it has also been acknowledged. So we want the service providers to have a well capacity to function during this COVID pandemic, because we never know how long this is going to last. So we shall thank you for your presentation. We shall thank you for your contribution in spite of having your personal issues during the early days of pandemic. Thank you, Saida. Now I request Dr. Sucharita. She is the coordinator of Asia Safe Abortion Partnership in India. And special thanks to Sucharita, because in spite of having her some family emergencies, she's been with us to share among all of us the experience, the community experience of India. Thank you, Dr. Sucharita. Please go ahead with your presentation. Thanks.
Thank you so much, Dr. Meera. First of all, I would like to thank the organizers for the opportunity to share my thoughts at this very important forum. And thank you for all those who spoke before me. I think a lot of what I'm saying is segueing very well with the opening remarks made by Professor Dilip Maulankar, Dr. Neena Rana, as well as what Dr. Manjula shared. So can I have the next slide, please? As Dr. Meera said, I'm going to speak about how far are we willing to go to leave no one behind. I think all of us are familiar with the phrase leave no one behind. But in the context of the talk we are having today, I thought it might be good to explore just how far are we willing to go to achieve those goals. Next, please. And before I start, I just wanted to say a little bit about the Asia Safe Abortion Partnership for those of you in the audience who may not be aware. The Asia Safe Abortion Partnership is a safe abortion rights advocacy network based in Asia. We have members from over 23 countries in South and Southeast Asia, Southwest Asia, and the Asia-Oceania region. If you check out our website, you will find the details about abortion laws and access in all the countries who are our members. Next, please. We work primarily with young people, and we also work with healthcare providers. We are doing a lot of work with a sort of a overlap of both the constituencies, and we've been working with medical students for the last few years, and that has been a very satisfying journey, and more information is available on our website. Next, please. We also maintain a strong online presence because we find that there is a lot of anti-choice information available online. And as you know, the politics of the online spaces reflects the offline or the real life spaces. So we make sure that we put out a lot of positive and evidence-based information on safe abortions on our website. Next, please. We conduct a lot of photo campaigns, which involves the young people. Next, please. And we have had a series of conversations called the COVID conversations, which are also available on our website for anyone who's interested in knowing more about these issues. Next, please. And a final announcement before I go to the main topic is that the Asia Safe Abortion Partnership will be organizing a conference in early 2022 called the Abortion and Reproductive Justice, the Unfinished Revolution Conference. So please do save the date and we will be in touch with you soon with more details. Next, please. So on to the topic for today, we speak of leave no one behind, and we know it is a core principle of the 2030 agenda. But do we ever think of where we are going? Is it this way, that way, somewhere else? What is actually guiding the direction in which we are moving? Next, please. So the 1978 Alma Ata Declaration focused on primary healthcare as a means to achieving health for all, with a focus on community participation. The community needs and priorities, their values and their vision for a healthcare system were seen as the guiding principles of achieving health for all. So in that sense, it was an idealistic vision of a community-led health system centered around the well-being of people. And what Dr. Manjula shared about, the concept of self-care or self-managed healthcare, not by abandoning them from the health sector, the public health sector system, but by including them within that and empowering them to actually take care of themselves, I thought was quite a good sort of circling back to this Alma Ata Declaration. Next, please. But real equality isn't possible if we don't celebrate our differences. So when we talk about leave no one behind, what is it that we are really looking at? And that is something that I'm going to try and unpack through the next 10 minutes of my presentation. Next, please. So despite all these declarations and policies and programs and various goals, as of now, at least half of the world's population still does not have full coverage of essential health services. About 100 million people are still being pushed into extreme poverty, defined as living on less than $2 a day because they have to pay for healthcare. And over 930 million, which is around 12% of the world's population, spend at least 10% of their household budgets to pay for healthcare. And these are statistics which are from the pre-COVID era. So as one can imagine, things are far more dire now that we are half a year into the pandemic, and definitely more people have been pushed into extreme poverty or have even less coverage of essential health services. Next, please. So in terms of the sexual and reproductive health issues, what are we looking at? So one is the maternal mortality rate, and as we can see from this map, and I will show you 2 or 3 maps, and you will see that there are a lot of coincidence between the maps where you have a high maternal mortality rate, a high unsafe abortion death rate, a high, critical shortage of healthcare service providers. And therefore, it is obvious that, the problems are overlapping, and therefore the statistics also show up in the same kind of countries. So if you could go to the next one, please. So percentage of married women age 15 to 49 with an unmet need for modern contraception. Again, one would see an overlap between the countries we saw in the earlier map. Next, please. The unsafe abortion-related deaths per 100,000 live births. Again, we can see that the countries which show high numbers are more or less having a similar overlap. Next, please. And the distribution of health service providers, as we can see again, very similar countries which have countries with which are having a critical shortage have again high numbers, same overlap with all the SRH issues. Next, please. So why does this happen? And I would like to remind us of what Audre Lorde said, that there is no such thing as a single issue struggle because we do not live single issue lives. And what Professor Mavlankar said in the beginning really resonated with me, with the story of Arjun and wanting to pierce the eye of the parrot with the arrow. But the reality is that, none of us have single issue lives. And that is something we need to recognize moving forward. Next, please. Because every person is also based or living at the intersections of all their other identities, whether it is age, gender, ethnicity, religion, class, culture, disability or ability and sexuality. And unless we are able to understand the intersections of these and make sure that they are protected from prejudices and vulnerabilities of all these identities, it's very difficult to make health as a single issue, deliverable. Next, please. So what do we say when we say leave no one behind? It means ending extreme poverty, reducing inequalities, and addressing discriminatory behaviors. What do we need to do all this? Next, please. We have to identify who is being left behind. We have to understand the reasons why they are being left behind. And we have to take positive action against the exclusion of these left behind groups and individuals. Now, in my presentation, I don't have time to go into the details to unpack, every particular part of this, but I thought I'll show you some images which will give us a sense of who are these people who are being left behind and why they are being left behind. Next, please. So here is an interesting quote I found from someone who was one of the architects of the MDGs. And they said that achieving the MDGs requires fundamental transformations in any society that transcends the techno fixes so that the most disadvantaged and vulnerable people receive higher priority. And they give us a list, which we all know: illiterate women, low caste children, single mothers, slum dwellers, subsistence farmers, the unemployed, disabled persons, households at the bottom of the ladder, ethnic minorities. And we know this is not an exhaustive list. But they also remind us that such transformations will never result from the application of standard recipes that often engender those discriminations in the first place. So basically, to simplify, what they are trying to say is we need to think out of the box. Next, please. And the problem I find is that if everyone is constantly urging us to think outside the box, then maybe it is the box that needs fixing. And I was very pleased to find that one of my favorite authors has actually said exactly the same thing that I always wonder. We're constantly told to think out of the box, but what is the box? And how do we identify that box? So I'm going to just enumerate what makes up the walls of this box within which we are kind of trapped. Next, please. So one is, of course, patriarchy. And I think any of these conversations, particularly around sexual and reproductive health rights of women and, gender non-conforming persons, cannot be discussed without understanding the concept of patriarchy, heteronormativity, neoliberalism, which is, sometimes described as capitalism on steroids, the whole issue with the urban-rural divide, the understanding that a healthcare facility needs to be a physical space with a healthcare provider present, which I think from Dr. Manjula's presentation also, in terms of telemedicine, self-care, maybe using drones, hopefully we are moving away from that. In terms of the digital divide, we do have a lot of good software and apps, etc., but there are many people who simply have no access to it. Religious conservatism, which may influence policies and programs rather than the human rights perspective, which should. Abortion laws, which are based on archaic colonial penal codes. The whole compromise of, safe abortion where legal, or repeatedly saying abortion is not family planning when we can see that for a lot of people it really is. So these are some of the walls of this box we need to be kind of chipping away at, so that we can move beyond it and actually make sure we leave no one behind. Next, please. So here are the images I'm going to show you. Who are the kind of people who get left behind? People who are forced into early and forced child marriages. Girls more often than boys, but here I found a photograph of both of them are obviously underage. Next, please. On the other hand, if they are not married, but they are being sort of allowed to go to school, this is the kind of access they have even for their schooling. And we know that in our parts of the world, most girls will drop out of school when they reach menarche because they are not able to maintain their menstrual hygiene in school, either due to lack of menstrual hygiene products or lack of bathrooms or lack of running water. Next, please. And look at the motivation of these girls wanting to go to school. So when you don't have roads, when you don't have control over your own body, possibly when they may be going to school but still not receiving sexuality education, so they're not really aware of what is happening with their bodies. Next, please. If and when they do get married, then there is no easy access to potable water. So, half their life is going to go in carrying heavy loads of water back and forth for, washing, cooking, drinking purposes. Next, please. When they fall ill, again, a lack of roads means that this is how you have to carry an unwell person to a healthcare facility. Next, please. And then we have the whole crisis of refugees, either caused by, human-made crisis, which could be due to war or some kind of conflict. Next, please. Or due to natural causes, which could be climate change, floods, or any other kind of natural disasters. Next, please. We have people who are migrant workers. So they are living in another country, not because they're refugees, but because they choose to. Although I would say the concept of choice, would be very loosely applied here. they are forced to, and a lot of these are women, and it is the women who suffer, and COVID-19 is potentially going to cause 25 million jobs to be lost globally, with these women migrant workers particularly vulnerable. So this is another large group that's going to get left behind. Next, please. And of course, when we look at the whole life cycle approach, older people tend to get left out of the focus of policies and programs as well. Next, please. People who are differently abled, again, very often left out of issues which require physical access. If you don't have information in Braille, if we don't have sign language interpretation, if we don't have slopes, simple thing like a slope can, change access for so many people. So the inclusiveness that we speak about needs to really be integrated within every single component of our healthcare services. Next, please. Those who are gender non-conforming or beyond identities beyond the gender binary again get left out. And I was happy to hear in Dr. Manjula's presentation, she spoke about the gender affirming surgery. But also we need to remember that trans men will often have a need for even abortion care, because not everyone undergoes the entire surgery, and many of them would still have a uterus and the potential for an unwanted pregnancy. And very often even in abortion care issues, we don't discuss that particular group which is vulnerable. Next, please. Again, we know that even pre-pandemic, there has been a very high number of women who are subjected to sexual and physical violence, and this has only increased now with COVID, where people have been in lockdown, in close confines with those who are actually the abusers or perpetrators of the violence. And here I just want to say that COVID-19 has really only magnified the gaps that already existed. A lot of it was already broken. It has just become worse, and it is now affecting people who were otherwise habituated to having easier access. So the educated, middle class, urban population is now facing the kind of barriers that all these other people I showed you photographs of have been facing their entire life for decades on end. So I think it's really more a shift in perspective that has allowed us to see really what needs to be changed. Rather than that COVID has actually made things so much worse. It was bad enough to start with already. Next, please. So here again, we spoke of removing, absolute poverty, and we can see the implications of poverty are not just that they can't afford healthcare, but that they live in places where it is almost impossible for them to stay healthy. Next, please. And of course, when you don't have systems where your healthcare is supported by the public sector, then what you can afford really depends on what you have. And sometimes that means either you have to take a loan or sell the only cow you have or mortgage your farm, or it means that you simply can't afford it and then you don't seek the healthcare. There aren't really too many options when you're that poor. Next, please.
Dr. Suchitra, you have 2 minutes time left.
Yes, I'll be done. As we can see, where you live dramatically affects your access to essential health services, and I think this is also very important for us to take into account. Next, please. Next, please. Yeah. And now with COVID, as you can see, this photograph has been taken from India, where everyone's wearing some kind of a covering on their face as a token response to COVID. But if you can see, there's absolutely no social distancing. Most of those masks are of no use because they are just like a single layer of cloth applied. So all the issues that we've been discussing, where the healthcare is already sort of, healthcare services are tottering from, various deficiencies and problems, are now going to be also overwhelmed by COVID. So it is going to be problematic, but I think we also need to step back and check that maybe 80% of it was already problematic to start with. So maybe we use COVID as an opportunity to view the old systems with a new lens. Next, please. In terms of family planning, and this was spoken about earlier, so I won't go into much detail, but yes, couples are unable to access contraception. So there are going to be a huge number of unintended pregnancies with the resulting outcome of increase in abortions, unsafe abortions, live births, as well as maternal deaths. This is data from India. Next, please. Projections. And there is a projected increase in maternal deaths. You can see there's a best case scenario and a worst case scenario, but in both of them, there is definitely going to be an increase in maternal deaths, and that's going to have a huge impact on all the programs and policies that we've been working on for the last couple of decades to bring down the maternal mortality rate in our part of the world. Next, please. So these are all the factors that affect the use of essential health services during the COVID-19 pandemic. But the main question to ask is who is actually accountable for making sure that these essential health interventions are provided to the people. Next, please. And that, as we know, in the human rights framework would have to be the government. And looking at India health expenditure per person, we can see that in the BRICS or any other newly industrialized nations, India actually spends the least on health per capita, of which again a bulk is out of pocket expenditure from the individuals themselves. And this is really not a sustainable or an ideal model to use going forward. Next, please. So I just want to say we know what is equality, we know how to talk about equity, but I think there is one more dimension we need to add to this conversation. Next, please. Which is that of going even beyond equality and equity and going towards empowerment. We need to not only help people overcome the barriers, we need to reach a point where there are no barriers and find some ways to redefine systems and access in such a way that everyone can access to the best of what they need to the easiest of their abilities. Next, please. And so maybe what we need to look at is not a jigsaw puzzle. Next, please. Maybe that's too simplistic. It's not a jigsaw puzzle. It's more like this very complicated circus, you've got to keep so many things up in the air. You've got to coordinate with so many systems, and it's important. You can't say health for all if you don't have roads, if you don't have potable drinking water, if you don't have sanitation facilities. So this reminds me of a quote by Rudolf Virchow, who is considered the founder of social medicine, who said medicine is nothing but a social science and politics is nothing but medicine on a large scale. And I think that is what the COVID pandemic has really, made true, the words he spoke about, a couple of 100 years ago. Next, please. So moving forward, when we talk of the community, and this looks like an illustration out of a children's book, but if you read carefully, it talks about, unstereotype avenue, toxic masculinity, recycling plant, inclusion square. So I thought this was a fun way to remind us of what we talk about when we say the community matters and community centric and leave no one behind. These are the people we need to make sure are not left behind. Next, please. And so to end, I would like to say this is what makes us healthy. The biggest effect is of the social determinants, but unfortunately that receives the smallest investment. Whereas individuals spend the biggest amount on medical services, which actually have the smallest impact on what really makes one healthy. Next, please. In A Long Walk to Freedom, Nelson Mandela wrote, "A nation should not be judged by how it treats its highest citizens, but its lowest ones." And that is so true. And leaving no one behind really is more than a programmatic issue. It's, I think, also a moral challenge of our age. And that is probably the lens with which we need to look at it. Next, please. And I would like to end with this quote by Arundhati Roy, who said that historically pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. And I do sincerely hope that all of us would take this opportunity to create a new normal, which will be very different from the old normal that we've been grappling with. Thank you so much once again for the opportunity to share my thoughts, and I'll end my presentation here.
Thank you. Thank you, Dr. Suchitra. This was really a wonderful presentation, and the most important was almost towards the end there was a slide where it was showing that equity, how we can reach to everyone, leaving no one behind. That was the most important slide I felt in your presentation, and that speaks a lot. So it is actually, you took us to the bare reality. And it is about it's about the social determinants of health, but now in emergency, it's also about the services, acceptability, accountability, and availability of the services to the people for any essential health services. So saying that, thank you so much for your presentation. So I will wait for Dr. Suchita's question now. Then I have received 2 questions to Bangladesh team, to Saida. And Saida has again replied in email because she has some internet issues. So the 2 questions were, one was, is there a provision of free mask and other PPE in district hospital, in Upazila hospital? And she answered that no. It has to be provided, it has to be bought by the clients themselves. And second question was, is there a provision of midwives giving MR services, that is a comprehensive abortion care service in Bangladesh, so which is called MR? So she said not all midwives give MR services. Only some selected midwives who are trained are allowed to give MR services. So these are the two questions I received from the panel, from the audience. Thank you so much. We still have 165 attendees in spite of having some problem in our IT system. So now I would like to thanks once again to all the panel members for being here and for sharing a very important presentation for our region, Southeast Asia region. Now I hand over my, thanking you all, I hand over my mic to Dr. Nina Rena for closing this webinar. Thank you so much. Thank you, madam. Thanks.
Thank you, Dr. Meera, for moderating it so well. And I think any webinar is a success if you have good panelists. And we had wonderful panelists on our webinar today who shared their experiences. I would like to thank Dr. Tana, Dr. Manjula, our colleagues from headquarters. I'll also like to thank Ms. Saida and Ms. Suchitra Dalvi from Inroads. I think there are very important key messages which are coming out of this webinar. And I would say that these are no surprises. First of all, the most important message, which is for all of us to really understand, is that this pandemic has, really alerted all the countries on member states, especially ministries of health and other ministries, that the whole of government approach is important. It's not only health, but then whole of government approach is extremely important for, to address any kind of pandemic, and this may not be the last one. Health workforce shortages have been highlighted by many presenters. How health workforce shortage really impacts the delivery of services and also brings on the burden on the existing health workforce who are either becoming sick, or many of our health workers, doctors, nurses, midwives have lost their lives as well, and they're called COVID warriors who have really provided services irrespective of the risk which they were taking. So I think this is something which has come out in a big way, that we need to really strengthen our health system. And then lockdown periods were imposed to really make sure that every country gets enough time to be able to strengthen their health system and get, in a state of readiness. I know there are many countries where a lot of donors came forward. They gave them ventilators, they gave them many other equipments. But the major problem was that those ventilators were lying like that, packed in hospitals, because there was nobody trained enough to be able to operate those ventilators. So I think trained health workforce is very, very important. And that was also highlighted by Saida when she said it is the availability, how personal, impact comes, the balance between personal life and professional life at this stage is extremely important. I think self-care guidelines have been there, as Dr. Manjula mentioned, since June 2019. But then the most important part is that these have been there. We have to encourage countries to make sure that these are adapted and these are used. And this is the time when self-care guidelines are extremely important, for people, for communities. So I think that's one part which is extremely important for member states to consider. How can you empower? And that really gets us to something which Suchitra mentioned, from equality to equity and to empowerment. And I think if we do not empower communities and we do not empower the interface between the health system and the communities and the people, then we are not likely to succeed, no matter how much investment is made, unless the empowerment of communities happen and there is a self-care which is promoted. I think we are going to be any number of investments in healthcare system strengthening would be always short of what we desire to achieve. The time, I think it's the WHO Academy is going to be working on these online courses. My request to all the audience is kindly download that app. It is very, very useful. Time is right, opportunity is unique, and approach is robust. I think the new normal is that, and what is we are using now is the online, a virtual platform to connect with each other. And probably this is going to stay with us for long. So the new normal is really how do we use these electronic platforms and IT platforms to be able to reach out to large numbers. And otherwise, most of the programs I've seen, they start with training and end with training. A lot of investments from face-to-face trainings are made. And this is a good opportunity for us to really invest in virtual trainings where we can really make a lot of difference. So I would say that it's very important that in addition to strengthening the health system, we also talk about risk communication. We also break some, elevate some myths which are being, there in the communities. We empower our communities, we strengthen our health system, and we make sure that there's a sense of social responsibility. I think Suchitra showed some pictures which are which is becoming a common sight not only in India but many countries where the use of mask and social distancing, the physical distancing of 6 feet is not maintained. And I think that's something which we cannot beat this pandemic alone only by strengthening health system unless we empower our communities with information, knowledge, and also some kind of a regulation. I know there are countries, including India, where now they have started putting, fine on if you're not wearing masks. There are many states which are practicing. There are many countries which are now trying to make sure that there is a, system whereby which you can force people to observe these protection measures, which are extremely important. And with these words, I would say that this is our last webinar, and we will get back to you soon with the same partnership, with some new additional webinars, because the task has not ended. But then I think we will make sure that we reach out to all of you. These will be there on the YouTube. You can review these, you can view them, and send us your feedback. On these webinars. And I'd like to thank IIPH Professor Dilip Mavlankar and his team. And I'll also like to thank Dr. Meera Upadhyay, who was responsible for coordinating these webinars with IIPH team. Kalpana, Neeraj, Amit, Meera, everybody. A big thank you, and thanks for making this such a big success. I know that many of you must be getting into your lunchtime. With all these words, I'd like to say that goodbye until we meet again, and hopefully, I think early next year we will start the series again. But then, until then, there are other series which are going on, which is on pediatric COVID-19 in children, and also we are going to be sending you information about school reopening, which we are doing in collaboration with UN partners. Thank you very much. Take care. Bye-bye.
Thank you very much, Neena ji. Thanks. We hope this partnership will continue. Sorry for the disturbance, yes, which I don't know why today it happened, but I'm sure we will get a lot of it on the recording, and a lot of important points were made. Thank you. Thank you.
Thank you. Those glitches are very, very common. Don't worry. I think we were able to get back quickly. No problem.
Yeah.
And I think our panelists could join. I think that was really good. And I see a lot of people join back again. Thank you. Bye-bye.
Bye-bye. Thank
We'll
you.
be in touch, Professor. Yeah.
Yeah.
Thank you.
Thank you.
Very, very common. Don't
Today